Hello everybody, today's topic is traumatic brain injury. So the management of the patient with acute primary brain injury involves the treatment of the primary cerebral insult, that is trauma, cerebral edema, tissue hypoxia and seizure, and avoidance of secondary brain injury from the extracerebral events. So the management of the traumatic brain injury is can be explained with the GHOST cap. It is a mnemonic which with the help of which we'll see how are we supposed to manage the case of traumatic brain injury. So the G stands for glucose. So the glucose is the main neuronal source of energy. So if hypoglycemia, that is the blood glucose level of less than equal to 80 mg, can impair the brain metabolism, and hyperglycemia, that is blood glucose level of more than or equal to 180 mg, has also been associated with the worse outcome. So in patient with acute brain injury, the tight glycemic control may not significantly improve the outcomes and may increase the risk of hypoglycemia. So the target should be between 80 to 180. So the next H stands for hemoglobin. So it is the important determinant of oxygen delivery. Though cerebral oxygen delivery is sufficient, so that when cerebral blood flow is reduced, the brain has enough physiological reserve. So cerebral blood flow can increase to preserve the oxygen delivery. Now this work is mainly done by hemoglobin. So if hemoglobin levels are low, then that is associated with the brain hypoxemia, cell energy dysfunction, and worse outcome. So it is advised to keep the hemoglobin level between 7 to 9. So now next is O, and the O stands for oxygen. It is the another important determinant of the delivery of the oxygen. And the hypoxemia is harmful to injured brain, but hyperexemia can be associated with the excitotoxicity and worse outcome. So target SpO2 level between 94 to 97% seems reasonable. Now the next is sodium S, and S stands for sodium concentration, which is altered in acute brain injury because of hyperosmolar fluid therapy, diabetes insipidus, inappropriate free fluid retention, increased natriuresis, and or AKI. So hypernatremia and hyponatremia has been associated to be independently associated with the worse outcome in a traumatic brain injury patient. So hyponatremia, that is the sodium level of less than 135, can contribute to the increased brain volume and the intracranial hypertension. The hypernatremia may occur as a result of intracranial pressure directed therapies. So sodium level up to 155 may be tolerated in such conditions. So next is T, and T stands for temperature. Hyperthermia is the part of systemic inflammatory reaction which occur after acute brain injury, and it is not at all associated with the infection. So hyperthermia can be associated with the increased ICP, cerebral hypoxemia, metabolic distress, and worse outcome. So whether fever has the prognostic implication in managing the traumatic brain injury is unclear, but definitely we should avoid the core temperature more than 38 degrees Celsius because it is associated with the neurological deterioration and altered cerebral homeostasis. Now, the C stands for patient comfort, which include control of pain, agitation, anxiety, shivering, and it is an important goal to avoid physical and physiological distress, excessive cerebral stimulation, increased ICP, and secondary tissue hypoxemia. The main aim is to keep patient calm, comfortable, and collaborative. Deep sedation may be required in some specific situations, such as elevated ICP, refractory status epilepticus, and severe shivering. Now next is A, which stands for arterial blood pressure. It is the main determinant of the cerebral blood flow. Even mild hypotension can result into the cerebral hypoperfusion, especially in pathological conditions such as impaired cerebral autoregulation, increased ICP, cerebral edema, and microvascular disturbances. So achieving optimum cerebral perfusion pressure is crucial. So the targeted map should be more than or equal to 80, and targeted cerebral perfusion pressure should be more than or equal to 60. Now the next is P, which stands for acute changes in the PCO2. carbon dioxide pressure, and it caused proportional changes in the cerebral blood flow, because every 4% change in cerebral blood flow per mmHg of change in PaCO2. If intracranial compliance is reduced, any increase in cerebral blood flow may increase cerebral blood volume and thereby IC. On the other hand, if we are if we are reducing PaCO2 excessively with the help of excessive hyperventilation, then it can cause vasoconstriction, it and it results into cerebral ischemia. So PaCO2 level of less than 35 mmHg should be avoided. Now, the individualizing this ghost cap concept, we can use we can do this with the help of non-invasive monitoring, such as cerebral ultrasound, near infrared spectroscopy, and EEG. But all these non-invasive things may be challenging. So we can make the use of invasive tools such as ICP monitoring, brain tissue oxygen pressure, and cerebral microdialysis. So this cartoon will summarize the overall ghost cap concept, which is G stands for glycemia, H hemoglobin, O is oxygen, S is sodium, T is temperature, C patient comfort, A arterial pressure, and C is P is PaCO2. Thank you.